lady. Just 1 minute. She presented with history of difficulty in walking, some heaviness and clumsiness of the left leg for the last 3 months. Just 1 minute. It was static and not improving. No complaints pertaining to the right leg or upper limbs or any other symptoms. And no sensory complaints. There's no headache or seizure. This is a video of the patient. So in complaints only one thing, difficulty due to some heaviness and clumsiness of left leg for the last 3 months. And this is the video of the patient. Illness normal. Illness normal, tongue normal, movements were normal. But the motor system examination don't appear normal in the eye. Or was also normal. All muscles are pretty much normal power. No incoordination in the upper limb. The lower limb, the tone appears actually spastic on the left lower limb. You can see that. Okay, normal on the right side. So this spastic. So the power was all grade 5. All working blocks on the left and right hand. There was no weakness as such. Reflex in the upper limb are slightly brisk compared to the right side. Eject is also brisk on the left side. It's also angle jet. Mandas of flexor bilateral. Even the left leg appeared stiff and spastic. The process this Pandora. Sensations are all normal. Vibrations also normal. Non-sensory is also normal. Okay, so let's get to the patient.
Your screen is
So sorry, the electricity went in between. Am I audible to you?
yes, sir.
Yeah. I'll share the screen once again. This is the gait of the patient. Walks with dragging of left lower limb and keeps the left hand in the between. Flex of the upper limb and not much mobility of the left hand. She also convinces some problem with the upper limb as well. So where do you think is the localization in this patient? She seems to have some stiffness on the left lower limb. Power normal. Detailed disc in the left upper and lower limb. Plantar downgoing.
Anywhere above the cervical cord, sir.
Right. So you think it's a which tract is affected? Do you think pyramidal tract is affected or some other system is affected?
Pyramidal.
Pyramidal. Okay. Right. So any other opinion anyone would like to make? Okay.
Basic ganglia and connections.
Yeah, because of the abnormal posturing of the left lower limb and lack of arm swing, no? Okay, but the reflexive disc on the left side. In this situation where it's difficult to differentiate between pyramidal and extrapyramidal, always look for abdominal reflex as well. So that's a given abdominal reflex be retained in extrapyramidal. Reflexes sometimes can be brisk, even extrapyramidal early Parkinson's, so it can be even brisk. Okay, so what investigation you need now? What other clinical tests will you do to confirm the site of lesion? Is it in the cervical cord or in the brain?
Tone.
Tone is upper limb were normal, left lower limb was stiff. You can see it was appearing like a spastic limb. So what I did was I looked for the hand dexterity. You can say what I am doing now is on the normal side. But see, with the normal power,
സോണിയെ കൊണ്ടാണ് ചപ്പാത്തി നല്ലതായിട്ട് ഉണ്ടാക്കിയിട്ടേ സോണിയെ പഠിക്കട്ടെ ഇതൊക്കെ താൻ സോണിയെ പഠിപ്പിക്കാതിരിക്കുന്ന ഏറ്റവും വലിയ കഷ്ടമാണ് താൻ ബലമായിട്ട് പഠിപ്പിക്കണം അല്ല സോണിയ നല്ലതായിട്ട് ചപ്പാത്തി ഉണ്ടാക്കി പഠിക്കട്ടെ അത് പിന്നെ ആവശ്യം വരും പിന്നെ എപ്പോഴാണ് ഇത് പഠിപ്പിക്കുന്നത് ഓ താനെതാണ്ട് വലിയ
Okay, I will show the video once again.
ഈ പ്രായത്തിലൊക്കെ പെട്ടെന്ന് പഠിച്ചെടുക്കുകയും ചെയ്യും.
Asmita, can you mute that particular person, please?
Yes, sir. I'm just doing that.
Okay. So that's a very clumsy hand on the left side. So then it also most likely to be a pyramidal lesion localized to the cortex and not to the cervical cord. Because there, in that case, you won't get that kind of a loss of dexterity with normal power on the left hand. Something like a limb kinetic apraxia-like phenomenon, where the patient has got normal power, but they cannot do the fine motor activity in a smooth fashion. So what do you want me to do now? Want to say look for something else? What investigation you need?
MRI brain.
Yeah, MRI brain, correct. This is the MRI brain. This is the flare sequence. I'll go one by one. Then the uppermost, this is the SWI. I'll show the other films also. Now this is the flare sequence from below upward. This is the SWI. I think this is a gradient sequence. Now let's see the T2. Looks normal. This is the 3D flare concentrating onto the cortex region. Nothing abnormal could be made out. No abnormality could be made out. We suspect the cortic lesion, but the cortic perimeter appeared normal. This is the flare sequence again and show once again. This is a zoomed up view of the flare.
ബ്രെയിൻ സ്റ്റിമുലേറ്റർ ഉണ്ടോ
This SWI.
In fact, the findings are on the left side. And then it's explained better.
Okay, so what else you need now? Any abnormality in the MRI brain? Looks normal or abnormal? Somebody should voice out some opinion, then only you can go on. Looks normal or abnormal? Am I audible to you? Hello?
Yes.
Yeah,
Yes, sir.
okay. It thinks normal, then we'll go to the other. So we did an MRI cervical spine. That's MRI cervical spine. This is the axial cut from downward. Normal. So what else you want to do now? Okay, let us see the pictures once again. Now we look very carefully. Use some white matter hyperdensity here in the subcortic in the corona radiata. Happiness in the pyramidal tract. Okay. Again, you can see the same thing here, little more. When you adjust the window width, you can little more see that clearly. Again, you can make it out there on both sides, coming down the hyperdensity in the pyramidal tract. Here again, you can make it out there. So there is hyperdensity in the pyramidal tract. So that is seen usually in ALS, but it's a very non-specific sign, not typical of ALS. Even old age, you can sometimes see that picture. Some demyelinating lesions also sometimes you find, like Krabbe's also you can find. Some white matter is also you can see kind of a hyperdensity along the pyramidal tract. But under the context with the pyramidal lesion in one hand, you have to keep an ALS is a strong possibility you have to keep in mind. So now look at this picture now. I'm showing the same picture which I shown earlier, but in the static picture. Any abnormality which you could make out? Anyone would want to make a comment on this SWI?
Sulcal
There is
hyperintensity.
some hyperintensity. Blooming there. Linear pattern.
Sulcal.
That can be sulcal hyperintensity maybe to the vein. What is more important is that look at the motor cortex. This is the handoff area, correct? There is a stream of hyperdensity or blooming seen along the cortex, motor cortex. See that? I will show the next cut. I will make it. This you see that you can make it out. This you can make a little more clearly. You can make out the blooming along the motor cortex. See this one? This is handoff area. It's more prominent on the right side, not much on the left side. Here, weaknesses are, and the clumsiness is also more on the left rather than the right side. So what is this sign called as? This sign is called as a motor band sign. So what motor band sign, where it is same ALS, motor neuron disease. So what else you want to do to confirm your diagnosis?
EMG NCS.
Yeah, EMG was the EMG. You can see fibrillation, precipitation, from the first to the intrusion. Forward. Mildly decreased only one. If the biceps nothing except for one fasciculation, first I think that's normal. It was good interference. The two bits and very conservative patient. Increase the interference. Right APB. So what is the diagnosis now? It's motor neuron disease. So this case is brought only to show that if you had problem in making an early diagnosis, this blooming along the motor cortex is a useful sign to differentiate it from other conditions. This is said to be very, not pathognomonic, but useful sign. Unlike the other hemocydrosis, confined only to the motor cortex. So let us see the two signs which are made out here. One is hypern density in the corticospinal tract in ALS. Increased T2 signal changes have been reported along the course of the corticospinal tract from subcortical precentral gyrus through the centrum semi-ovate, which you have seen here, posterior limb of internal capsule, that also we have seen, several peduncles, pons, and medullary pyramids, anterior and lateral corticospinal tracts of the spinal cord. These MR changes have been thought to represent corticospinal degeneration. However, they are not sensitive or specific for MND, can be associated with even normal aging. Motor band sign, the striking feature of in SWA in ALS is the exclusive involvement of the bilateral motor cortex, that is Brodmann's area 4 or primary motor component, in a band-like fashion called the motor band sign. Hypointensity in the gray matter of the precentral gyrus in SWA and T2 is presumably related to the iron accumulation proportionate to the severity of the human involvement. This patient, we had more on the left upper limb is more affected. The blooming is more seen on the right motor cortex. Why this blooming occurs is not exactly clear. It is postulated that perhaps microglia accumulate this iron as the phagocyte degenerating neurons from the primary motor cortex. This is a postulate. This one, the textbook picture. Okay, that's the case. So any questions in this case?
Sir, is this motor band sign seen in the early course of the disease or later on?
I didn't get you. Can you repeat once again?
Is it seen in the early course of ALS or when it is very advanced?
No, it can be seen even in the early case. The only thing is, see, our patient had only early motor neuron disease. The only abnormality in the hand area was only pulses of the left hand. But still this blowing was seen. But it not be seen in all the cases, maybe seen some cases. He had no weakness of the left hand at all. No spasticity, only consonance was there. Left lower limb was spastic, but no weakness. Shall I go to next case?
Yes.
Yeah. This is another interesting case, not a common one. This is a story of a 40-year-old man. He was detected to be diabetic since the age of 31 years. In December 2021, his complaint started as edema of the right leg, associated with high-grade fever, followed 2 days later by vomiting. He was seen by a physician and he detected a right inguinal lymphadenopathy and biopsy was done. Biopsy report came as Castleman's disease. He was seen by a rheumatologist and was given one course of rituximab, which ended in March 15, 2022. Following which, the patient again remained asymptomatic for nearly 1 month. Edema became less but was still persisting. After 1 month, patient developed periods of fever, shivering and vomiting, lasting for 4 to 5 days, which is continuing even now. The last episode of fever was 1 week back. 3 months back, patient noticed difficulty in climbing stairs, loosening of the chappals for both feet, followed 1 month later by difficulty in buttoning the shirt. For the last 2 months, he noticed numbness of tips of fingers. So this is the story. Everything in this is important. Non-diabetic. Complaint started in December 21 as edema of the right leg with fever. At that time, physician detected right inguinal lymphadenopathy and the biopsy came as Castleman's disease. Patient rituximab was given and edema became worse. After 1 month, patient developed periods of fever, shivering and vomiting, lasting for 4 to 5 days, which is continuing even now. Last episode of fever was 1 week back. 3 months back, patient noticed difficulty in climbing stairs and loosening of the chappals from the feet, followed 1 month later by difficulty in buttoning the shirt. For the last 2 months, he noticed numbness of tips of fingers. Now, on examination, the right leg was edematous, as you can see there. This is the examination findings. Tailors are all normal.
ഈ ലൈറ്റിലോട്ട് നോക്ക്, ലൈറ്റിലോട്ട് ഇവിടെ മുകളിൽ താഴെ. ശരി, പല്ലി അടച്ചേ, കണ്ണ് മുറുക്കി അടയ്ക്കുക, മുറുക്കി അടയ്ക്ക്, മുറുക്കി അടച്ചേ, മുറുക്കി അടയ്ക്ക്, മുറുക്കി അടയ്ക്ക്. വന്നോ, ശ്രമിക്കുക, ഞാൻ ഒന്ന് കണ്ടുപിടിച്ചോട്ടെ. മതി മതി മതി. ആന്ന് പറ. ആ ശബ്ദം ഉണ്ടാക്ക്. നാക്ക് അങ്ങോട്ടും തള്ളിക്ക്.
Normal.
മുമ്പോട്ട് തള്ളി,
Neck muscles are also normal.
ബാക്കിലോട്ട് തള്ളിക്ക്. മതി.
To the motor system, he had wasting of the small muscles of both hands. You can see the wasting of the first two sheep. Tone was normal.
മുറുക്കി പിടിച്ചേ, മാക്സിമം പിടിച്ചോ.
Hand grip was normal,
മുറുക്കി പിടി.
but small muscles are weak, which you can see later on. Also muscles are all normal power.
നൂത്തെ
Biceps.
മടക്കിക്ക്, നൂത്തെ വിട്ടോ, ഇതിനെ പൊക്കിക്ക്.
Wrist extension were normal.
വേട്ടയ്ക്കിനെ അകത്തി പിടിച്ചോണേ. മാക്സിമം ശ്രമിച്ച് നോക്കട്ടെ. വിരൽ മടക്കിക്ക്, മടക്ക്, നൂത്തെ.
The indorsio were weak.
ശ്രമിക്കേ, അത്രയോ നൂത്തെ. ശരി, വിട്ടോ. അകത്തോട്ട്
Long finger presses above were normal.
മടക്കിക്ക്, മതി, വിട്ടോ. ഇങ്ങോട്ട് തള്ളിക്ക്,
Abductors, finger abductors weak.
ഇങ്ങോട്ട് തള്ളു, ഇങ്ങോട്ട് തള്ള, ഇങ്ങോട്ട് തള്ളിക്ക്. ഇതിങ്ങനെ പിടിച്ചോ.
Performance was positive bilateral.
ഊരാ സമ്മതിക്കല്ലേ, ശ്രമിച്ചേ. വിട്ടോ, തള്ളവരൽ സഹായം എടുക്കരുതേ.
Palmar adductors are also normal. No finger nose incoordination.
മറ്റേ കേണ്ടി ചെയ്ത് ചെറുവലയെ നിർത്തി പിടിച്ചിങ്ങനെ കണ്ണടിച്ചോ.
There's no pseudoarthritis.
കണ്ണ് പതുക്കെ.
So, the lower limb Proximal muscles are normal power.
ഇത് പൊക്കിക്കോ.
Outlying examination.
ഇത് മടക്കി.
Quadriceps normal.
ഇത് മടക്കിക്കേ. നോർത്തെ. ചവിട്ടിയൊക്കെ മാറ്റി. ആദ്യം മുകളിലോട്ട് എടുത്തേ. പറ്റി മുകളിലോട്ട് ഇരിക്കണം.
Both muscles are over weak.
സമ്മതിക്കല്ലേ? ഇങ്ങനെ പിടിക്കണമേ. കേട്ടൊക്കെ സമ്മതിക്കരുത്. ഇതും പിടിച്ചേ. സമ്മതിക്കരുത്. പിടിച്ചോ.
Okay, more weak on the right side than the
പിടിച്ചേ.
left.
ഇങ്ങനെ ഇരിക്കണേ. പറ്റണില്ല. ഇത് പൊക്കട്ടെ. എൻ്റെ കൈ ചവിട്ട്. ആഞ്ഞ് ചവിട്ട്. ചവിട്ട്.
Plantax is also mainly weak.
തള്ളവരുടെ കീഴോട്ട് മടക്ക്.
Pectoralis longus is also
മടക്കി
weak.
പിടിച്ചോ. ഇത് മടക്കി പിടി. ഇതകത്തോട്ട് ഇങ്ങനെ പിടിച്ചേ. ഇതകത്തോട്ട് പിടിച്ചോ.
Inverted was
ഇനി
normal.
വെള്ളോട്ട്
Inversion was
ഇങ്ങനെ ഇരിക്കട്ടെ. ഇങ്ങനെ ഇരിക്കട്ടെ. ഇതെങ്ങനെ ഇരിക്കട്ടെ. മതി വിട്ടോ.
Abductors, adductors normal.
ചേർത്ത് വേ. അകത്താ സമ്മതിക്കല്ലേ. മതി. റിപ്പോർട്ട് തള്ളി. എൻ്റെ കയ്യിലോട്ട് തള്ളു. തള്ളിക്ക്. മതി വിട്ടോ. ഇതും തള്ളിക്ക്. വിട്ടോ.
Compressive are all absent, both upper and lower.
ഇതും കൊടുക്കണ്ട.
Flexors are also absent. Intercrossed absent. And both knee and ankle tips are also
മുട്ട്
absent.
മടക്കിക്ക്. ഞാൻ പറയുമ്പോൾ കൈ മുറുക്കി പിടിക്കണേ. രണ്ട് കൈ മുറുക്കി പിടിക്കണേ. ആ നീട്ടി വെച്ച്.
Plantar is indefinite.
ഇനി
From the
ശ്രദ്ധിച്ച്.
sensory system, I think will run much forward. Just could impaired touch the distal part of the both the lower limb. Upper limbs it was normal. It's also got decreased pain. The lower limb.
വേദനയുണ്ട്.
Up
അത്
to the
വളരെ
knee.
ശ്രദ്ധിച്ചിരിക്കണം. ശ്രദ്ധ വിട്ടുപോയി.
You will point out. That's the area where you're feeling normal.
അവരുടെ കൈ പറയണം.
The upper limb is also impaired in the distal part.
കൂടുമ്പോൾ
So the neck rate is impaired.
വൈബ്രേഷൻ. ആ വൈബ്രേഷൻ എവിടെയോ?
Vibration however was normal in the upper limb.
ഇപ്പൊ ഉണ്ടോ? ഏ? ഉണ്ട്. ഇപ്പോഴോ? ഇപ്പോഴോ? ഈ വെച്ചതും
But mild impairment are seen on the distal part.
താഴെ കുറവാ. ഇതും
I'm comparing possibilities.
ഇപ്പോഴോ? ഉണ്ടല്ലോ.
But vibration is also impaired over both
ഉണ്ട്.
limbs.
ഇപ്പോഴോ?
Is it less? Not present.
ഇപ്പൊ എങ്ങനെയാ?
The joint is also impaired in both fingers and toes.
ഇപ്പോഴോ? ഇപ്പോഴോ? ഇപ്പോഴേ? ഇപ്പോഴേ?
It's also impaired.
അറിഞ്ഞൂടെങ്കിൽ അറിഞ്ഞു.
With the gait of the patient,
കണക്കിന് ഇപ്പൊ ഉണ്ട്. പേടിക്കണ്ടേ?
thrombus is positive.
കണ്ണടച്ച്. കണ്ണടച്ചോ? എവിടെയായാലും പിടിക്കും. പിടിക്കാതെ. ശരി, കണ്ണ് തുറന്ന്. എൻ്റെ കൈ പിടിക്കും. ഇങ്ങനെ നിൽക്കണം.
He cannot walk on stand on heel or toes. He can walk, he cannot walk on that.
നീ ഉപ്പൂറ്റി പോകും.
Those muscles are more weak than on the plantar.
ഇവിടെ ഇരുന്ന്.
He found difficulty in getting up from the floor and not from the stool. Then he could get up. From here, he had mild difficulty, indicating the proximal also affected to little extent. Gait up is almost normal. Over tandem walking was difficult. So summarizing the examination findings, tail nose normal, except for cori bilateral verticularis weakness. Motor system upper limb, wasting of the small muscles of both hands. Tone normal, power weakness of all small muscles of both hands. Long finger flexes, extensions, other muscles, muscles were all normal. Lower limb tone normal. However, weakness of both dorsiflexes, EHL, flexor hallucis longus, and plantar flexes, mild weakness. Mild postural muscle weakness in the form of difficulty in getting up from the floor. Knee muscles were appeared normal. PTR, upper limb all absent, lower limb all absent. Plantar flexor. Sensory touch is impaired over both the legs below mid-shin. Pain is also decreased over the distal part of both the legs and hands. Vibration impaired over both toes. JPS impaired over both fingers and toes. Rhombus mildly positive, gait normal, tandem walking impaired. So what is a neurological diagnosis? Just nothing great in that.
Radicular neuropathy.
Yeah, it could be radicular neuropathy or peripheral neuropathy. Both can be predominantly affecting the distal part with wasting, more like a peripheral neuropathy or a radicular neuropathy as well, because the proximal reflexes are also absent. Now, what are these episodes of fever, shivering, and back pain and apprehension the patient has been having? But there is one major complaint is complaining now. Every 2 weeks he had these episodes. And in fact, I did not give much importance to the complaint. And only I was looking at the peripheral neuropathy part of it. Then subsequently came, when I asked to come to follow up, even before that he came with that one episode of that fever and shiver. I was able to record one of the episode. So I was able to get video of one of the episode of fever, shivering, and palpitation. And along with that, he also complaining of backache. And this used to occur once in 2 weeks, even after 2 months of having taken rituximab. This is one such episode. In back it started. He said feels extremely fatigued. He was having fever. He felt fatigued and started shivering. The started developing back pain. This is shivering he had. Remember, initially he did not have that shivering. Examined him previously. This time there was no weakness on the limbs or anything. In the episode, no worsening. The reflexes also remained the same, but you can make out the shivering of the patient. You can see the shivering of the hands. So in fact, I go back to the investigation. This is the video, patient which I have seen now in September 2019 and 2022. I'll go back to the investigations done earlier. That is in December 2021, he was initially diagnosed with Castleman disease. He went to the physician and detected a bilateral equivalent femoral lymph nodes, largest in the right femoral region. They did a CT scan which showed multiple small, enlarged, non-calcified, non-necrotic lymph nodes in the right equivalent location, likely infective or inflammatory. Histopathology report from the right equivalent gland. The first report, they could not make a definitive diagnosis. Lymph nodes showing reactive follicular hyperplasia and interfollicular plasmacytosis. And he was advised a second opinion. The second opinion said the histopathology, or the second opinion of the histopathology was that IHC immunohistochemistry follicles are positive for CD20. Then immunofluorescent cells are positive for CD30, CD3, and some other BCL2Ka, I do not know what that thing. Anyway, findings are sensitive of Castleman disease plasma cell type. That is the opinion of the final opinion of the lymphadenopathy they took. Now, the investigation is done in February 22. At that time, his gamma globulin was elevated, IgG gamma globulin was elevated, IgM was normal, Ig was mild elevation, and the light chain kappa was also elevated. Normal is up to 19, it was 39. The lambda fraction was negative, normal. And they did an ISC marker for human herpes virus 8 was positive. This immunoreactive score 3+ in the neoplastic cells. Then did FDG PET, which showed minimally FDG avid right inguinal and right external iliac nodes, known case of Castleman disease, biopsy proven. No other metabolically active lymph nodal distillation same. This is the FDG PET. I think we skip that. It is in February 22. He was given the rituximab based on the diagnosis of Castleman disease based on the biopsy of the implant. Then they did an immunodeficiency panel was done, which is all normal. His absolute lymphocyte count, CD3, CD1, all normal. Then to find out the progression of the disease, they did a repeat PET CT in May 22. Initially, it was given in February. Then in the 5th month, they did it again. That shows when compared to the previously whole body FDG PET dated 10th of February, the present study shows metabolic resolution and decrease in the size of the previously dated FDG avid, right external iliac and right inguinal lymph nodes. No new lesion or FDG avid other lymph nodal or external nodal involvement was seen. The ANA profile was negative. These DNA, Joe, everything was negative. Then in April 22, they was detected to be diabetic. So, no, this was the initial presentation. When he started developing his peripheral neuropathy at the local hospital, he was investigated for the neuropathies. And they did an anti-nuclear antibody, which and Pienga and Cienga, which is also normal. ANA profile is also normal in the previous hospital as well. They did an NCV, which showed absent potentials from the both peroneal and tibial when they picked up from the ADB and abductor hallucis. But TA pickup at the gastropic was also decreased in amplitude. And in the upper limb, curiously, the left upper limb, even though both hands showed wasting and weakness, the amplitude was decreased in the left ulna and probably maximum affected in the left ulna. If you look at the FA, there is a curious finding in that the peroneal FA is absent as suspected because the CMAP amplitude is very low. But in the median, both median left and both ulnar, there is FA wave prolonged. So as probably as suggested, thought earlier, maybe he had a radicular neuropathy as well, because otherwise, why should he have a normal CMAP amplitude and normal distal latency? Should have a prolonged FA latency. For example, look at the left median. Is a latency is 3.8 millisecond and velocity is normal 51, but FA is prolonged. That means that there is a proximal prolongation of the conduction in the proximal part, proximal to the stimulating point. Maybe in the radical or proximal part of the nerve. The sensory potential was not picked up from the supraorbital peroneal and the sural, but in the median and ulnar nerves were normal. So they report electrical studies as sensory motor axon neuropathy, but there is some suggestion of a demyelination because of the prolonged FA latency with the normal distal latency and conduction velocity, suggestive of a radicular or a proximal nerve movement. But that to demyelination. They did an M band, immunotyping was done, look for the IgM band. There was no M spike was seen in the immunoelectrophoresis. So serum protein profile by capillary electrophoresis does not reveal presence of an abnormal peak. No M spike is seen in immunoelectrophoresis. So in August 22, repeat abdominal ultrasound was done, which did not reveal any organomegaly, no epidermomegaly. That's the time when the patient came here, and the examination which I showed you earlier was when I saw the patient in September 19th. So patient came here saying there was no improvement for his neuropathic symptoms and for the episodes of fever, backache, and palpitation and shivering. So I repeated the NCS in the PRS hospital in September 22. The findings are almost same, except that it has become worsened. The peroneal lower limb findings are same, but the right ulnar was also affected just like before. But here the sensory potential become abnormal even in the upper limb also. It was normal in the previous NCV. Now it has become affected in the both ulnar and in the upper limb. And if you look at on the other hand, FA prolongation, which was seen earlier, was decreased a little bit now. Except that the right ulnar is inelicitable, and left ulnar was which is prolonged. But it is still there, but in the median that has improved. So probably mononeuritis multiplex versus radicular neuropathy, asymmetrical radicular neuropathy is the probable diagnosis. But it's not purely demyelinating because it's got axonal features as well as demyelinating features. Now, what do you think the etiology of the neuropathy in this patient? And what is causing is episodes of fever, shivering, and all. In fact, I was not. Yeah, please.
So that IgG levels were elevated, no, sir, in this case.
Correct. IgG was elevated.
Yes. Can we say this is a macroglobulinemia, Waldenström's macroglobulinemia, something like that?
No, but he had he was a proven case of Castleman disease. I had previously one case of a child, young person who had peripheral neuropathy, something and papilledema and organomegaly. I was a Poem syndrome. That patient did not had short Castleman disease. So Castleman disease can be associated with Poem syndrome. So I can only make out these patients got peripheral neuropathy, but no other definite clues to suggest a Poem syndrome. It's no organomegaly, no skin changes, no endocrinopathy, and no M-band. So anyway, I wanted to rule out the other, whether it could be poems in this patient. So is it poem? That is my question. Is it peripheral that's what is Castleman disease, or is it poems? So I did a CSF. CSF showed a protein at 270, but telling you that patient's got a radicular involvement as well in this patient. So it's not a peripheral neuropathy, it's got a radicular neuropathy. Cell count is only 3. Then I did a cervical survey because this is done it for whether it could be poems or not, because the poem is, as you know, can be associated with solitary osteosclerotic myeloma. So this was done. This cervical survey was done. There was no evidence of any myelomatous lesions anywhere in the whole spine, thoracic, lumbar, up to the pelvis ended. Everything will be seen. Then they did the skull and cervical upper part again. That is not show any evidence of myeloma. Even the upper cervical spine. So I rechecked the M band. Again, there is no M band in this patient. No features of poems that's for definite. Now, what is this condition? In fact, I was also not knowing what is. I did a repeat CD19 to find out whether his symptoms are recurrent because it's inadequate immunosuppression, because the rituximab was not effective or not. So, however, it was effective because the CD19 census only 0. So that means the rituximab has worked, but still is becoming symptomatic. What else can we do with this patient? That is the problem.
HHV8 associated Castleman's, no, sir, this one.
Exactly. This is HHV8 associated. Yeah, that's a calculation in this case. So that is a, I'll come to that. In fact, I was not knowing much about this condition. I was not knowing that HHV8 can be associated with Castleman disease. So I sent a such a literature. Now, Castleman disease describes a group of 3 immunological disorders that occur in individuals of all ages and share a similar microscopic lymph node appearance, with signs and symptoms related to the release of cytokines, particularly interleukin 6. It's a rare lymphoproliferative disorder characterized by enlarged lymph nodes and a broad spectrum of clinical manifestations. It is divided into 3 pathological types: hyaline, vascular, plasma cell, and mixed cell. Our patient had a plasma cell type of Castleman disease. It can be unicentric, that be confined only to one region, or multicentric, as in our patients. And patient multicentric disease will most often present constitutional symptoms, reflective, excessive, pro-inflammatory cytokainemia. Furthermore, interleukin 6 is thought to play a major role in the pathogenesis of Castleman disease. Unicentric, as already told before, there are 3 types. One is unicentric, involving single region. In the HHV8 associated multicentric Castleman, there may be 2 types. One is HHV8 associated, other not associated with HHV8. This involves multiple regions of enlarged lymph nodes with CD-like features, flu-like symptoms, abnormal blood count, and dysfunction of the vital organs due to uncontrolled infection with HHV8. Now, HHV8 negative or idiopathic multicentric Castleman disease involves again multiple regions of enlarged lymph nodes with Castleman disease-like features, flu-like symptoms, abnormal blood count, and dysfunction of vital organs due to unknown cause. Now, the flu, what is the symptom? Our patient had HHV8 associated Castleman disease. So, what is the symptomatology? The flu-like symptoms. Just like a patient had fever, night sweats that soak the sheets, weight loss, loss of appetite, weakness, fatigue, shortness of breath and cough, nausea and vomiting, numbness and weakness, leg edema, skin rashes. Our patient had leg edema, hemangioma, and pemphigus and kappa. These are the features of symptomatology HHV8. Now, regarding the neuropathic part, 25% of the patients with Castleman disease had an associated neuropathy with or without Poem syndrome. Only if it is a peripheropathy alone, it's a mildest, often purely sensory without pain. In a CD with Poem syndrome or Poem syndrome without Castleman disease, share a severe, commonly painful sensory motor neuropathy and polyradicular neuropathy. Poems is a more severe clinically electrophysiologically. Poems, those associated with Poems is more severe clinically electrophysiologically. That is, Poems without Castleman disease is more severe compared to Castleman disease with Poems. I think I will skip that thing. Now, this is the thing which we are interested in. Some Castleman disease patients experience systemic inflammatory symptoms like fever, fatigue, excessive sweating, weight loss, skin rash, as well as laboratory abnormalities such as low hemoglobin, elevated CRP. They are seen typically in multicentric Castleman disease. And this is thought to be caused by the excessive IL-6 in a portion of the patients. So what the treatment, what you are giving is not rituximab. We have to give a treatment for the IL-6 inhibitor. That is what is required in this patient. Up to now, we only know about the rituximab for treating. The maximum is the rituximab we give as an immunosuppressant or endoxine. But here we have to give a drug which inhibits the IL-6 because that is responsible for the paroxysmal episodes of fever, fatigue, shivering, etc. And this is effective in 44% of the patients. I think I'll skip all these things. The prognosis part and all. So that's the story of it. So patient, I wrote a letter back to the oncologist that you have to give some IL-6 inhibitor, either tocilizumab or cetuximab, which is as given in the literature. That's the only way to control the symptom in this patient. Because rituximab did not work in this patient. He developed neuropathy while he was on rituximab. Nearly continued to have this kind of a inflammatory reactions even on immunosuppression with the CD20 suppression, even with the rituximab. So, any questions?
Sir,
No,
that are that constitutional symptoms similar to like cytokine storm
Yeah.
seen in
right, exactly.
coronavirus? Sir.
Yeah, exactly. Something like similar to cytokine. Exactly. But here different is that it occurs as a burst. Whenever the cytokine occurs, patient has the symptoms. At other times, it is not there. In the interleukin is released on the bloodstream, you get symptoms. So we have to give a block that interleukin 6, the patient becomes a symptom. No, it's nothing. I mean, it's only I bought this case only because it's a rare case.
Rare and very interesting, sir.
Yeah.
We have never heard about this, sir.
I had only one case of Castleman, and that was associated with Poem syndrome. That boy had osteosclerotic manner. Okay.
Yes, sir.
They may have already suspected a HHP. No, they have sent an HHP.
Because they did a gland biopsy, and that was suggestive Castleman. Whenever you get a Castleman, you have to look for immunohistamine state for HHP8. That's the 3 types. One is unicentric, multicentric 2 type, HHV8 positive, HHV8 negative.
The prognosis differs. If HHP8 is positive, then the prognosis is bad.
Yeah. That's it. MCD is also the best prognosis, with deaths reported in 2 years of diagnosis. Good prognosis when treated with rituximab with greater than 95% survival to patients who do not respond to rituximab alone, chemotherapy agents may be added to control the disease. Okay.
Yes, sir.
Shall I go to the next case?
Yes, sir.
Yes, sir.
In fact, this case is not my case. This is given to me by Dr. Maharishmi and Dr. Professor Balaji from Chengalpet Medical College, when they had gone there to visit that college. Now, this is a story of a 62-year-old male. Now, this case is brought only to show some interesting findings in that patient. He had past history of left hemiparesis 2 years back, and the weakness improved over 1 year. For the past 6 months, patient has slowness in activities, walking difficulty, tends to walk faster and become unsteady, tremors the right upper and lower limb more during rest, and inappropriate laughter. Shared Parkinsonian features, but that should not produce inappropriate laughter. That means it may be, if it is pseudobulbar, it is a typical Parkinsonism, or maybe some frontal lobe dysfunction. Let us see. Now, in fact, I'll show some certain cardinal findings in this patient, which may be interesting. Most of you know about these findings, but it's once a while to refresh our memory. It's better to see this kind of findings. Now, this here, the patient is, what I'm showing is that I take the comprehension first, which is normal.
Very good.
Then he has to ask, I'm an object.
Brush வச்சு எப்படி தேய்ப்பீங்க? அப்படி தேய்க்கணுமா? சரி, ஓகே. தலை எப்படி சீவுவீங்க? ஓகே, ஓகே, ஓகே. டாடா.
Are you able to follow what you're saying? Is Tamil?
எப்படி காட்டுவீங்க? டாடா.
I will play once again because it has stopped in between.
கீழ வச்சுக்கோங்க. இடது கை தூக்குங்க. வெரி குட். கீழ வச்சுக்கோங்க. சரி. பல் எப்படி தேய்ப்பீங்க?
How to brush.
பிரஷ் வச்சு எப்படி தேய்ப்பீங்க?
Brush washing, how to do with the brush.
அப்படி தேய்க்கணுமா? சரி, ஓகே. தலை எப்படி சீவுவீங்க? ஓகே, ஓகே, ஓகே. டாடா எப்படி காட்டுவீங்க? டாடா. அவங்கள வாங்கன்னு கூப்பிடுங்க.
எம்மா வாங்க.
ஓகே. எப்படி கூப்பிடுங்க? கையால கூப்பிடுங்க.
எம்மோ.
இங்க 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 மேடம கூப்பிடுங்க.
எம்மா வா.
கையால எப்படி கூப்பிடுவீங்க?
எம்மா வா.
சரி.
So he has got transitive and intransitive praxis is normal. He has got, he can use, imagine, he can mime an imaginary object, and the intransitive, he can communicate with gestures are also normal. He could do it, he couldn't do it normally. I am asking the next one. It's asked to imitate actions done by the examiner. This is Maharishmi sitting in front. He could mime, he could imitate what the examiner was doing. The imitating is normal. Then checking the gesture comprehension. That is the comprehending the action done by the others. What is that action? It's asking what I am doing. He's telling this. He's telling that I am saluting, I am brushing all. So he has got a good gesture comprehension. Gesture comprehension in that. Then coming to the conceptual appraisal testing, the tool object action and tool object selection knowledge.
பூட்ட திறக்கிறதுக்கு எது யூஸ் பண்ணுவாங்க? பூட்ட திறக்கிறதுக்கா எப்படி பண்ணுவாங்க? திருக்கணும்.
Which is the object used to
தலை சீவுறதுக்கு எது?
What is the object used to brush?
தலை சீவி காட்டுங்க.
That means you could select the correct tool for a particular action. The conceptual knowledge is in that.
பூட்ட திறக்கிறதுக்கு எது யூஸ் பண்ணுவாங்க?
Okay. Now let's see the video of the same patient using with the left hand.
சரி. அந்த கையில பல் எப்படி தேய்ப்பீங்க? அந்த கையில தேய்ச்சு காட்டுங்க.
It has to do with the left hand.
பல் எப்படி தேய்ப்பீங்க?
It has to brush the teeth.
எப்படி? இந்த கையில தேய்ச்சு காட்டுங்க. சரி, ஓகே. தலை எப்படி சீவுவீங்க? தலை எப்படி
Ask him to brush the hair.
தலை எப்படி சீவுவீங்க?
Comb the hair.
சரி, டாடா காட்டுங்க.
Ask him to say tata.
டாடா எப்படி காட்டுவீங்க? டாடா காட்டுங்க. டாடா காட்டுங்க. டாடா அந்த கையில காட்டுங்க. அந்த கையில டாடா காட்டுங்க. டாடா காட்டுங்க. டாடா எப்படி? இந்த கையில காட்டுங்க. சரி, அந்த கையில காட்டுங்க. சரி.
Okay. So he could not do mime and action with the left hand.
சரி.
But could do very well with that.
பல் எப்படி
Let's say
தேய்ப்பீங்க?
I don't
அந்த கையில
know.
தேய்ச்சு காட்டுங்க.
Now let us this video. Patient is asked to imitate with the left.
டாடா காட்டுங்க அந்த கையில. நான் பண்றத பண்ணுங்க. டாடா.
He could not imitate what the examiner is doing.
பல்லு தேய்ங்க. இங்க பாருங்க. நான் பண்ற மாதிரி பண்ணுங்க. நான் எப்படி பண்றேன்? இந்த கையில பண்ணுங்க.
You can do with the right hand.
இந்த கையில பண்ணுங்கடா.
You cannot imitate with the left hand. So you cannot imitate with the left hand, can do with the right hand. You're touching the concept of praxis.
பூட்ட திறக்கிறதுக்கு எது யூஸ் பண்ணுவாங்க?
Same thing we have shown earlier.
எப்படி பண்ணுவாங்க? திருக்கணும். சரி, ஓகே. தலை சீவுறதுக்கு எது? சரி, தலை சீவி காட்டுங்க.
Now you ask to do with the left
இந்த
hand.
கையில சீவி காட்டுங்க. சீவி காட்டுங்க.
He held it correctly,
ட்ரை பண்ணுங்க.
but could not do it correctly with the left hand.
Okay.
Did correctly with the right hand. So even with the object in hand, this praxis was affected on the left hand. So he cannot mime an action with the left hand. He cannot do, even with the object in the left hand, he could not do, and he cannot imitate a movement with the left hand. So all the three types of grades of apraxia were affected on the left side, but all were normal on the right side.
பூட்ட திறக்கிறதுக்கு எது?
So in summary, is good pantomime to verbal command, which is impaired on the left side. Imitation of gestures, normal on the right side, impaired on the left side. Ability to action with the object in the hand, impaired on the left. and he's got good gesture knowledge, and concept knowledge is also normal. He could choose which tool is for a particular action. I can also name what is action demonstrated by the examiner. So where is the site of lesion in this patient?
Anterior corpus callosum or the left premotor cortex.
Very good. That's the thing. So this is the anterior corpus, the callosal apraxia.
Not left, sir, right, sorry.
Right.
Right premotor cortex. Callosum.
More often it is due to the callosal lesion, because with the premotor cortex is affected, usually they are associated weakness also. So the apraxia part may be usually missed, because it may be there, but because underlying weakness may mask the apraxia part. As when Praveshwar was telling correctly, that can also occur with the right premotor cortex lesion. Now, this is you can see very clearly the site of involvement here, the corpus callosum here, anterior corpus callosum. It's also middle part is also affected, that later. Now let us see. Okay, this video I shown yesterday for another meeting, but for those who have not seen this patient, this is the same patient where this abnormality. So what do you think the patient was having?
Abnormal grasp.
Not a grasp. In fact, it's
Mutation.
this is more than a grasp.
Mutation.
This is actually is groping. When you show the target, is groping towards the hand. Just a visual stimulus make the patient approach towards the visual stimulus. That is what is called this is called magnetic apraxia. Even if you say, "Don't follow my hand," you will follow that. So this is actually one type of a defective response inhibition. So when you see a stimulus, this patient is compelled to reach that particular stimulus. Even if you ask them not to follow the stimulus, they are compelled to do that. That is a defective response inhibition. What is a normal response? Whenever you see symptoms, we try to grasp onto that. Normally we don't do that. But that response inhibition is not there in these patients. It's called magnetic apraxia. You hear the apraxia is actually, it's a misnomer. Mind you, this is not apraxia. This is a release phenomenon or a primitive reflex which is released. Here the patient sense will approach moving objects that they see and to which they attend. These are disorders of defective response inhibition. That is inability to withhold a response to a sensory stimulus. This defective response inhibition is defined as responding when no response of that body part is required. It can be seen in the eyes and limbs. One type of defective response inhibition is what is called a Minhagen. That means very slight pressure leads to movement in any direction. It may be tactile, that when you touch the limb, the patient will follow that limb. The other is facilitative paratonia. The usual paratonia, the Gegenhalten, is that the patient tried to inhibit, resist your movement. But here, the patient will help your movement. Suppose you want to do the flexion extension movement, the patient will help you to flex it, help you to extend. Whereas the classical paratonia, the frontal paratonia, they keep on resisting your movement with variable period. At times he may resist and he may not resist like that. It's a variability is there, but they resist movement. That's a classical paratonia. In facilitatory, these people tend to help the examiner to you move it. So that's a facilitative one. Then the visual facial grasp is that when you look at the patient's face, he will not able to disengage particular face to another new stimulus. There is again an acute. These are all what you call various forms of stimulus boundedness. Stimulus boundedness is approached here. Usually, what is been told that the frontal lobe foster avoidance behavior and parietal lobe foster approach behavior. So approach means the parietal lobe tend to approach to the thing stimulus, whereas the frontal lobe tend to inhibit that. As always, frontal lobe do all inhibit your other emotional, other activities. So it tend to inhibit. So this, what happened in prefrontal lobe lesion is that the inhibition of the parietal lobe, which mediates approach behavior, is removed. So they tend to show this stimulus boundedness approach, tendency to approach to the stimulus. The other is magnetic apraxia, as already told you, the one which I showed in the video. If anything else, skip this thing.
Sir, the waxy flexibility is part of that facilitated paratonia.
No, waxy flexibility is entirely different. That is a catatonia where there is continuous, the patient tend to keep the new position for long. And you've got to continue, if you want to move it uniformly, it will just like a severe rigidity, it will be continuously present. It is not an action of the patient that you do it. In the case of when your question was you want to differentiate from ordinary Gegenhalten one waxy flexibility, right? But
yes, sir.
Yeah, that's a good question. So what happens in waxy flexibility, that is uniformly present all through. Whereas here in Gegenhalten, that is variable. Sometimes he may do it, sometimes he may not do it, resist it. The resistance again may vary with time. Now let's go to the other positive findings in these patients. His attention was normal, language impaired reading, but writing was normal. So can corpus callosal lesion, spinal lesion can produce impaired reading? Only corpus callosum without effect in the corto-occipital lobe. In the classical and the alexia without agraphia, lesion should involve the subangular gyrus or the dominant occipital lobe and the splenium. That is a classical description. But a splenial lesion alone sometimes can produce what is called hemialexia. Hemialexia means he cannot, when there's a word is there, he can only read half of the word. He cannot comprehend the meaning of half of the word. So only read the half of it. That's called hemialexia, that is described in the splenial lesions. This patient, we did not check that. He had impaired reading. Otherwise normal. His verbal memory was normal. Visual memory was impaired, indicating a right temporal lobe involvement. And he had found other frontal lobe testing. He had impaired lexical fluency and extremity dysfunction. This is the writing is fairly okay. Now this is the clock drawing. What is your interpretation about this clock drawing? Which he did?
Hemi neglect on the right side.
Okay, you mean the left side?
Yeah, yes, sir.
You know, if this is not hemi neglect is there, but that's not the main abnormality. Just in hemi neglect alone, why should he draw numbers like this? That means he's totally lost the concept of a clock, one. Second, he's repeating the same letters again and again. For example, if you look at the 2, he's repeating 2 times. 6 repeating many times. So again, what other letter is also repeating. So that means he has got a loss of concept of the clock. This is a part of executive function. Second, he has got a perseveration. That's also a part of a executive function. And in addition, he has got a hemi neglect as well. But main thing was the frontal lobe dysfunction. So loss of concept of the clock and perseveration indicating dysfunction, and some degree hemi neglect to try to indicate right parietal dysfunction. Again, he has got the series completion all defective, indicating an executive dysfunction. Now coming to the sensory system, primary motor sensations were normal. Cortical sensation was impaired on the left side. Tactile localization was impaired. Bilateral sensory stimulation is also inattention, and stereognosis also impaired on the left side. And graphesthesia impaired on the left side. So indicating a right parietal lesion. So this patient had hymen function abnormality indicate bifrontal dysfunction and right anterior corpus callosal involvement or right premotor cortex as told, and as well as right parietal dysfunction because of his hemi neglect part of it, as well as the defective cortical sensory impairment. It's also got a constitutional pressure, as you can clearly see here. I think the other things I will skip. It's also got features of pyramidal signs. We just developed, extrapyramidal cells just developed recently. So the syndrome is that.
Why the
yeah.
Why the writing is impaired? Is it writing is impaired in this case?
No, writing is normal. That I'll show you once again.
No.
She did again. Surprised, no? His writing is perfectly related to normal. Good writing. If you look at this is what the doctor has written, Maharashtra has written. That is what he has written. See, it's almost normal. If you couldn't read Tamil, still you can make out they are normal.
Amma.
Okay. Okay. That means the left-sided parietal lobe is intact. Misaffection is only in the right parietal lobe. And why the reading problem is maybe hemilexia in this patient. But we have to look carefully whether enable read was due to that. So here Parkinsonism, that is only a recent thing. Recent memory impairment, callosal apraxia, left cortical sensation impairment, dressing apraxia, consistent apraxia. So where is the localization? As told before, this is the MRI of the patient. See the corpus callosal lesion. It's also called splenial lesion. Probably that is causing his hemilexia part of it. Inability to read on the left half of the page, the left half of the word, that can cause inability to read. Again, you get splenial lesion. And the main trend was on the right subcortical frontal parietal lesion. That is the frontal lesion. This, in fact, MRI was not now. This was taken 6 months back when the patient had hemiplegia on the left side. That is why you see the diffusion restriction now. This is not the MRI which is taken recently, the old MRI. So that's the story of the patient. Now, this case I brought only to demonstrate the interesting findings of that the type of left-sided apraxia confined to the left side, and the method of testing the apraxia, and the gesture comprehension, how you do that. Gesture comprehension indicates that the left parietal lobe is intact. That's the area where the concept of the movement engrams are stored. If that is defective, the patient will not be able to understand the action done by the other people. Suppose you do an action, you cannot say what action it is, and you cannot choose a correct tool for a particular action to be done. That is object tool selection, object tool action praxis. So then the other things, all of you know that left cortical sensitive, that's not important.
Sir, is it a ideational or ideomotor apraxia on the left side? Sir?
Yeah, in fact, it's an ideomotor apraxia. This ideational apraxia is no longer nowadays used. Initially, it was coined for, universally said that when you say ideational apraxia, the patient is unable to sequence a complex motor act. The sequencing part is not part of a praxis testing. Okay, that's actually occipital dysfunction also, patient will not be able to sequence a motor act. Nowadays, this ideational apraxia is removed, and that is replaced with the conceptual apraxia. Conceptual apraxia indicates one, the gesture comprehension, the comprehending what the action of other people. Second, your tool selection, that means for a particular, suppose the patient is showing an action, he cannot be able to do the action. Similarly, he cannot, suppose you want to say drive a nail into the plank. He will not be able to use which tool to be, take which tool to be used. For example, instead of taking a hammer, he will take a screwdriver to drive a nail onto the plank. That means his tool selection praxis is there. Then the other is tool object action. So he may take the correct tool. For example, you find a nail, he chooses the hammer, takes the hammer correctly, but instead of pounding the nail down, he may be scraping onto the plank. Then he has lost the concept of the motor action to be done with that particular tool. So these two things will come under conceptual apraxia or the so-called ideation apraxia. This is now replaced by conceptual apraxia. This indicates the lesion is usually diffuse, but usually indicated the left parietal lobe is affected.
Okay, sir. Thank you.
Any other question? And it's not a challenging case, but still it's good to know this. Seldom we come across this kind of interesting finding. That's what I choose the patient.
So why there is a pseudobulbar effect in this case, sir? Multiple infarct.
Here, in fact, he got inappropriate jocularity. He's jovial. And yes, see, when you examine it, so sometimes you look here and there because he's attracted to things all around. Again, it's a kind of an environmental dependency syndrome or a approach behavior. But whatever stimulus come in the way, he will approach to that, tend to attend to that stimulus. And the jocularity is not aware of his disability. So it's got sometimes a loss on its own. Probably that jocularity is a part of the prefrontal lobe dysfunction, orbitofrontal dysfunction. Okay, I think it's time now, so we'll stop here. Only 5 minutes left. This I'll tell later on. Okay. Or shall we go with one more case? Or stop here with this case or one more case?
One more case.
Short case. Okay.
Yes.
It's a tremulousness of right hand since 2018. Remember, this is a 34-year-old man, tremor for the last 15 years. In fact, the tremor was not noticed by him. His co-workers noticed that his right hand was tremulous when he was walking, but he did not bother much about that tremor. However, it became more prominent for the last 3 years. It is present at rest and also during action. There's no other complaint other than the tremor. So this is a tremor of the patient. This is a tremor.
ഞാൻ പറയുമ്പോഴേ ആ കൈ കൊണ്ട് ആ ടോർച്ച് എടുത്ത് എൻ്റെ കയ്യിൽ തരണം. ഇനി ടോർച്ച് എടുത്ത് give it to me.
Less during an action, but present mainly during.
93, 92, 91, 89.
Ask him to divert his attention. Ask him counting backward, the tremor increases. And when you divert the attention by counting backward, the tremor also appears the right foot. See the right foot also occasionally. But he had no akinesia, no facial features of other features of Parkinson's. Mild postal tremor, but rest tremor was more prominent. Look at the gait of the patient. A normal gait.
Go on walking.
So, it's rest and postal tremor more at rest, increase of diverting attention. So, what do you think is happening? Yes, what is your opinion?
Parkinson. Tremor dominant Parkinson's.
15 years with no other features of Parkinson's.
But is on walking also there is a less arm swing on the right side.
No, it is not very much. He was deliberately slowly, but his walking otherwise is normal.
So there is a lower limb is also affected, sir.
Correct.
Right.
So he has got, as you said correctly, when tremor occurs in one side of the body, right, it's almost invariably is Parkinson's disease. So, but it was surprising why 15 years he not have any the symptoms. So he was put on Pacitin twice daily. With that, he's not given simple Pacitin. Then the diagnosis is a benign tremulous Parkinson. Benign tremulous Parkinsonism, when the tremor remains for a long period of time. The patient's advised a Trodac scan and showed decreased uptake on the left hemisphere. In decrease on the left side. When he says he was significant dopaminergic transport abnormalities in bilateral putamen, left burst more than the right. So patient came after 1 month for Pacitin 101. His tremor almost totally disappeared. Except for the man. Nowadays, people hesitate to start Pacitin. I always start in tremor dominant Parkinson's as the first line. Okay, this gate. This is the gate. So nothing great in this case, but I was surprised why for 15 years he was having this tremor only without other any features of Parkinson's. That was really surprising. Any questions?
So any family history in this case, any mutation?
No family. I specifically asked for them, no family history. No family history, no consanguinity. Okay.
Is it possible to have a Parkin mutation in this case or something like because early onset?
Yeah, I don't know. It is a tremor remain like that. Usually Parkin mutations start with the dystonia and akinesia to start with. They got good prognosis, but they got dystonia is the one of the cardinal feature of Parkin mutation.
Okay.
This literature says something called a benign tremulous Parkinsonism, which remains as tremulous for a long period of time. I had seen another patient also, but it is not long as 15 years. 5-6 years, he had only tremor, no other feature. Then we developed ultimately Parkinsonian features. Okay. Can we close it now?
Yes, sir.
Okay.
Yes, sir.
Thank you all.
Thank you. Thank you. Thank you very much, sir.
Thank you, sir.
Good night, sir.
Good night, sir.
Thank you.
Thank you. Thank you all.
Thank you, sir.